Okay, and we can move now to the final part that is more interactive, let's say, with a Q&A session. And so please send your questions in the Q&A button on the bottom of your screen. I have a few questions for you already about the trial. First, about safety. Do we have any idea of the role of the dose in hypertension? Is it dose related? Can it be modulated? Is it seen more in higher doses when you have to increase the dose, or can it be present from the beginning in lower doses?
Yeah, certainly happens with lower doses too, but clearly the numbers of patients who have hypertension goes up with dose increases. Also with duration of therapy. So even if the dose isn't necessarily going up, certainly patients are on like the 1.33 or 1.75. With additional treatments over time, we do see increasing hypertension. I had a few patients on trial as well as off trial who, didn't have any significant hypertension for months, and then all of a sudden developed hypertension on study. So, certainly my recommendation would be, and then the guidance in the trial is to regularly check blood pressures with every dose and really kind of key in on it. And for most patients, a simple addition of an antihypertension medication or adjustment of their current antihypertensives can bring those blood pressures back down.
That's very helpful. Thank you. We were also a bit disappointed at the beginning of the trials to see very few responses in the cohorts without drugs. So what is your let's say, idea on the rationale of this kind of synergistic effect with ruxolitinib that doesn't seem to be, so clear when it's used in monotherapy?
Yeah, it doesn't make a lot of sense, admittedly, because if you think about it, so conversely, the Rux cohort seemed to have the most responses. And that doesn't make sense, because if you think about ruxolitinib blocking the EPO pathway, EPO really affects early differentiation. So that might make more sense from when you think about it that way. So if ruxolitinib is lowering the effect of the natural EPO in the body, thus kind of slowing early differentiation by pushing late differentiation with luspatercept, you might be able to overcome the cytopenic toxicity of ruxolitinib. So while I can't explain why there were fewer responses in the less, the non-transfusion dependent patients, at least the patients on Rux who are transfusion dependent, you might postulate why. But it wasn't really consistent cohort. And I think, a search for a good biomarker that associates with response, independent of whether they're on Rux or transfusion dependent, I think is needed to help sort out why.
That's great. And probably you're right. We like combo therapies usually, and probably it will be maybe even better with ACVR1 inhibition. If we combine that with momelotinib or pacritinib, maybe. That's an interesting future perspective, I think.
Yeah. Every talk I ever see folks give, like yourself or Dr. Mascarenhas and others who kind of focus on the whole anemia, there's always a slide about how anemia is multifactorial. So it only makes sense to kind of hit it with a couple of different weapons, right? A couple of different pathways to really try to improve anemia. You look at the best drugs that improve anemia in myelofibrosis, and it doesn't fix everyone's anemia. And it doesn't do, it does with some durability, but not infinite durability. And so hitting anemia in a couple of different ways makes complete sense. Hitting anemia of inflammation by lowering hepcidin levels through ACVR1 inhibition, pushing late differentiation with luspatercept really is and combining those is an attractive option.
Great. We have questions about trials of luspatercept that are planned or in progress. I think you answered the question. And this related question is, should I enroll my transfusion-dependent MF patient in the independence trial? So it's a complicated question, or very precise, but please, yeah.
Yeah, I mean, like yourself being a clinical trialist, I truly believe that enrolling patients on study when you can should be the first option. No matter if it's a low-risk patient, high-risk patient, if there's a trial available for that patient, I think that's the preferable option. And when we put together guidelines like the NCCN guidelines, we do our best to try to emphasize that point. The independence trial is ongoing. And so I think if the patient's a good candidate for the study and potentially eligible, I would certainly encourage enrollment. Of course, if the patient's not eligible for the study or can't get on it or doesn't have access, Luspatercept, at least here in the United States, is available off-label for use, and is endorsed by the guidelines in certain situations, as you mentioned. So it's tough, but we want to get the data, right? Without the data, we can't further develop these therapies and get them out to more patients. So highly encourage enrollment on clinical trials.
Okay, I fully agree with you. And maybe a last question in the chat coming from, it's an honor to have Tiziano Barbui with us today. Thank you, Tiziano, very much for attending this session. And he asked a question that is really, I think, relevant. Anemia is sometimes a factor for indication to bone marrow transplant. To what extent the new anti-anemic drugs can prevent or avoid bone marrow transplantation?
Wow, that, yeah, like you, I have to begin with I'm absolutely honored that Professor Barbui joined us today. Yeah, I think that's a great question. So there's some emerging evidence with momelotinib, at least, that patients who have anemia responses on momelotinib have significantly improved survival compared to what would normally be expected for those patients, comparing to those who do not have an anemia response. And perhaps as we have more effective agents in the space, we need to circle back and think about our prognostic models. I don't think we need more prognostic models, but maybe we need to think about that in a more dynamic fashion where, anemia is obviously an adverse prognostic factor, but maybe anemia response to an agent like a luspatercept or a momelotinib might reverse that adverse prognosis. And in someone who's kind of on the border, in terms of risk, it might push you to delay transplant a little bit. Someone who's high risk, who has an anemia response, is still high risk. I would still pursue transplant. Someone with a very high DIPS score or very, very high MIPS score, particularly those driven by cytogenetics and mutations, even if they're having an anemia response on luspatercept or momelotinib or some other agent, I would probably still lean towards transplanting them because it may not be durable and the disease might progress in other ways that could be adverse.
Very, very helpful. Thank you very much.